Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Mirum Pharmaceuticals.
Hello, I'm Thomas Berg, Professor of Medicine at the University of Leipzig Medical Center in Leipzig, Germany. So welcome to this program titled, Should we be thinking more about bile acids in progressive cholestatic liver disease? I'm very pleased to be joined today by Verena Keitel-Anselmino. She's professor at University Hospital Otto von Guericke in Magdeburg. So, hi, welcome, Verena.
Hello, Thomas.
So I think we have an exciting quickfire today, and where we, Verena and I, will ask each other questions. And we have only a very limited time, 60, 90, or 120 seconds to respond. And we want to explore the relationship between bile acids and cholestatic liver disease, and whether this can unlock new insights into disease progression and management strategies. I think it's a very important topic, right, Verena? And we have a lot to discuss. So let's get started with the first question. So, Verena, first, why think about bile acids in liver disease? And is it sufficient to measure total serum bile acids, or do they need to be differentiated? A bit complicated question, but are you able to answer in 60 seconds?
Thank you, Thomas. Who knows me knows I'm in love with bile acids. Bile acids are synthesized within the hepatocyte and then excreted into bile. And similar to bilirubin, they can be used to measure hepatobiliary excretion and thus add some additional information for us on bile formation in our patients. So bilirubin is excreted by MRP2, also encoded by ABCC2, while our bile acids are excreted by the bile salt export pump, which is encoded by the ABCB11 gene. And while everybody measures bilirubin in hepatology and gastroenterology to also look at the prognosis of liver diseases, we don't routinely measure bile acids. And I think they actually add a lot of valuable information. And the second question was whether we need to differentiate them. And we don't need to do this in clinical practice, but differentiation can help us get more insight onto the hepatobiliary excretion and also the microbiome.
Great, Verena. You really managed to stay in time with this question.
So, Thomas, what are the consequences if bile acids accumulate? And could you differentiate between accumulation within the hepatocyte and outside the hepatocyte?
Yeah, that's important, Verena. And high bile acids within the hepatocytes are toxic. So you have ALT, AST elevation, inflammation, and eventually liver fibrosis. Whereas the accumulation outside the hepatocytes affect other liver cells, mainly biliary cells, but also immune cells. But in the systemic circulation, they can also damage other organs. For patients having bile acid accumulation, you have typical symptoms. And the most common, of course, is itching. But patients may also experience symptoms like fatigue, abdominal discomfort, dark urine, pale stools. And over time, if it lasts, bile acid retention can cause malabsorption of fat-soluble vitamins. And that could lead also to specific symptoms like bone pain or fractures or bruises, hematomas, but also night blindness, we should not forget. So it's important to recognize these signs in order for timely intervention. So Verena, let's talk about the mechanism behind bile acids in the liver leading to pruritus? Can you answer this?
Well, this is actually quite a difficult question, and not all the answers have been solved yet. But what we have to keep in mind that it depends where the bile acids accumulate. So if you have a blockage of bile acid uptake into the hepatocyte, as we can do now therapeutically, for example, in hepatitis D treatment, bile acids accumulate in the systemic circulation, but not in the hepatocyte. And those patients don't have any itch. So for hepatic itch to progress, you need accumulation in the liver, in the hepatocyte, and also disturbed enterohepatic circulation. And probably bile acids themselves, but also other substances, which we call pruritogens, play an important role here. And they comprise bile acids, but also lysophospholipids, and also progesterone derivatives. And they then in turn stimulate different itch receptors, but also different itch neurons. And this explains that we don't have one pruritogen and one itch receptor, that patients are quite different in response to their itch, and also that we probably don't get the magic bullet treating all patients with the same drug, but we have to interfere in the cycle at different pathways. So in summary, we don't have one pruritogen, we have several. Bile acids are probably an indirect marker. They may cause itch in some patients. In most patients, it's probably other substances that are excreted into bile.
Excellent. Very complicated. It's not only bile acids, we learned.
Yes. So you already talked about inflammation before, but could you explain us how accumulation of bile acids in the liver triggers inflammation and thus liver damage?
When bile acids accumulate in the liver due to impaired bile flow, of course, we call it cholestasis, they become toxic to liver cells, as mentioned. But this happens through several mechanisms. First of all, a direct toxicity. It's well known that excess bile acids disrupt cell membranes, and this leads to hepatocyte injury and hepatocyte cell death. But there's also oxidative stress. So bile acids could generate free radicals, causing this kind of oxidative damage in liver tissue. And a third hallmark is the activation of inflammatory pathways. So bile acids can trigger certain signaling pathways like NF-kappa B, and this leads to the release of inflammatory cytokines and further damage the liver. So altogether, there's also immune activation because retained bile acids attract immune cells, which then amplify inflammation and fibrosis. All these chronic inflammatory processes caused by bile acids stimulates scar tissue formation, progression to fibrosis and cirrhosis. So to summarize, bile acid accumulation is a key driver of liver inflammation and damage. And through the toxicity, direct toxicity, oxidative stress, and immune activation, ultimately leading to fibrosis, cirrhosis, and eventually liver failure.
Thank you, Thomas. This was a really difficult question, so a little bit over, in my opinion, is okay.
So, Verena, now what is the impact of elevated bile acids on other organs, not only the liver?
Yeah, Thomas, I already told you we have bile acid receptors, and we actually have them almost everywhere in the body, including the brain and the adrenals. But just to answer your question, I will focus on a few where we have more information on the bile acid effects. For example, if you think about the kidney, some of our cholestatic patients develop cholestatic nephropathy. So bile acids can be excreted via urine, but they can be retained in the tubular cells and cause kidney damage. Then you already mentioned that we have systemic effects like fatigue. In the intestine, we have the malabsorption of fat-soluble vitamins causing different effects like bone mineral density reduction, also vision impairment, and we have metabolic alterations. So we know bile acids alter lipid and glucose metabolism, but they can also act on the heart. And this is very important in intrahepatic cholestasis of pregnancy because the fetal heart is not immune against bile acids, but this can cause arrhythmias, So in intrahepatic cholestasis of pregnancy, towards the end of the pregnancy, if bile acids are really, really high in the mom, and we will talk about this later again, this can have a severe impact.
Verena, I think you were a bit over time, but an excellent response. Thank you so much.
So if we talk about elevated bile acids all the time, what are the conditions that we see elevated bile acids commonly both in adults and pediatric cohorts, Thomas?
Elevated bile acid levels occur, I think, in several conditions. First, we can talk about cholestatic diseases, and perhaps this is the most common cause in adults, where there is bile duct obstruction, such as gallstones, tumors, secondary sclerosing cholangitis. In neonates, the most common cause is biliary atresia. And then in adults, we have very common causes like PBC, primary biliary cholangitis, or primary sclerosing cholangitis. But I think it can be also seen in cholestatic drug-induced liver disease, and there's often a genetic background. The second group where we have elevated bile acids are those with advanced chronic liver disease, mainly cirrhosis, severe acute liver injury, where bile acid excretion is reduced. And a very interesting group are those with hereditary cholestatic diseases. And in children, but also in adults, we have the progressive familial intrahepatic cholestasis syndromes, the PFICs and Alagille. And this is a major cause where genetic defects disrupt the bile acid transport. And then, as you mentioned, in pregnancy, we have the intrahepatic cholestasis of pregnancy. So in summary, I think bile acids elevation span a wide range of conditions, from inflammatory bile duct diseases in adults to genetic disorders, and requires condition-specific management. But how fast is the progression of these diseases and conditions? Could you give us an update here, Verena?
Oh, this is a difficult question, because it's very hard to predict how bile acids influence liver disease. This depends on multiple factors, and it not only includes the disease you're looking at and the disease severity. For example, PBC is much less progressive than, for example, PFIC, as you just described in the children. They progress much more rapidly than our adult patients with PBC or also PSC. Then the level of the bile acids may play a role. So in these children, we see very, very high bile acid levels, and they progress rather rapidly. And what we also know, you said this in your answer just before, in chronic liver disease cirrhosis, as liver disease progresses, bile acids elevate and then could further also the progression. And then we have to keep in mind other factors of our patient, like age, comorbidities, drug intake, alcohol intake. So when should we measure bile acids, Thomas? I'm looking forward to your answer.
Perhaps we do not measure bile acids often enough, and we mentioned in the beginning that they could be helpful in differentiating the underlying liver disease. So I would say serum bile acid should be measured if you have an unexplained cholestatic disease, especially in patients with pruritus, high bilirubin levels, or fluctuating jaundice, of course, when there's no bile duct obstruction. We mentioned pregnancy. I think here it's quite clear, if you have itching, ALT elevation in pregnancy, you should check for bile acids. But there's perhaps a large group with unexplained liver enzyme elevation. But here, if it's unexplained, measuring bile acids can provide additional diagnostic clues. So if you have a situation with high AST, ALT in combination with high serum bile acids, this suggests an impaired bile acid secretion, and this could have a genetic background. And then, of course, we have the chronic cholestatic diseases, as we mentioned, starting from the genetic cholestatic disease like PFIC, PBC, PSC, where it could be an important marker. So these markers, the bile acids, are valuable for diagnosing and monitoring cholestatic disease. particularly in the presence of pruritus, jaundice, or unexplained liver dysfunction.
I completely agree. We should look at them more often.
Yeah, but then how often should we measure serum bile acids depending on the diagnosis?
So you have to consider different situations. So if you have a patient, as we talked about, with very high bile acids, and you have this person on a treatment for lowering serum bile acids, then at the beginning you will look much more closely. If they normalize or come within the range where you want to get, then you can extend the intervals where you look. If you have a patient, for example, advanced liver disease, and you don't have them on any treatment and they don't have any new symptoms, you probably don't have to look at them very often. But if something changes, there is more severe pruritus, disease progression, then I like to look. And as you said before, ICP is the time we really need to look. So itch and pregnancy is mandatory to look at bile acids. And then you have to keep monitoring them unless they already raised above 100, because then you know the child is at risk towards end of pregnancy, and we should talk to the obstetrics team and the patient to consider delivery. So in summary, I think in clinical practice overall, we should do it a little bit more often, but probably we don't have to do it each time we see a patient. So Thomas, how should serum bile acid levels be interpreted in terms of prognosis? How should they inform clinical decision making? And could you also comment on how ursodeoxycholic acid influences bile acid levels? This is a difficult one.
Yeah, yes, Verena, but serum bile acids and their level are important markers for both prognosis and clinical decision making in cholestasis. As a prognostic marker, elevated bile acid levels are strongly associated with disease progression, especially in these forms of hereditary cholestatic disease and also Alagille syndrome and biliary atresia. They are also of prognostic value as they can indicate a more severe cholestasis with an increased risk of fibrosis. But they are also helpful in guiding treatment decisions, so they may identify those patients who may mostly benefit from bile acid lowering therapies, such as the IBAT inhibitors, which directly reduce bile acid retention. And during therapy, we can use serum bile acids to monitor the effectiveness of our bile acid lowering therapy. I think that's also very important. You also mentioned the role of urso, and urso is a bile acid, so how does it influence our diagnostic accuracy of serum bile acid measurement? And although also therapy can in some patients lead to a mild increase of bile acids, let's say up to 2-3-fold the upper limit of normal, this does not generally impact treatment decisions, as urso primarily improves bile flow and reduces inflammation rather than impacting directly bile acid levels. So in summary, I think serum bile acid levels are crucial for assessing prognosis and optimizing treatment, particularly in diseases where targeted therapies like IBAT inhibitors are used. So my next question to you, Verena, is in terms of management, how would you deal with minimal pruritus but high serum bile acid levels? How do these parameters inform your decision?
Well, this is exactly what we already talked about, that pruritus is not only bile acids, but more. But this is interesting. So we have to look at the underlying disease. So if you have very high bile acid levels and mild symptoms, this could suggest also hereditary cholestatic liver disease. I mean, some of these patients have really severe itch, while others don't. So we're thinking about FIC or a similar kind of spectrum of disease. And if you have confirmed the diagnosis, we do have approved IBAT inhibitors for this disease, and they are approved for the disease and not for pruritus. And we have data suggesting that if you lower the serum bile acids, you could actually prolong native liver survival. So that would definitely be a case where I would want to use them. And also the high serum bile acid levels can indicate an active cholestasis. So we should also look at what is the liver function like in these patients? Is there any new biliary obstruction if it's not a genetic cause? And we should also assess disease severity and also how the disease progresses. And then we should think about other forms of therapy. For example, in an ABCB4 patient, they may not have that much itch, but they could benefit from an urso treatment to protect their bile ducts from these high bile acid levels. And as I said, for PFIC, also another disease, as you mentioned, those diseases where bile acids are prognostic, lowering them could actually mean that we prolong liver survival, can maybe prevent transplant at an early age. And so we would want to look at that. And in a patient with these high serum bile acids, we would definitely monitor them and also the liver function to figure out what's going on if our intervention helps the patient, prevents disease progression, and maybe improve outcome in the end. So I have a question for you. When do these patients need to be sent to a specialist? So when do they get to see you?
Yeah, this is always a very important question related to liver diseases, because elevated ALT levels are so quite often seen also in primary care. But I think there are two main scenarios where you should think about a specialized referral. And the one is the patient with unexplained liver enzyme elevation. We mentioned it. So if they remain elevated for a long-term period, so more than a year, without a clear cause, especially if these liver enzyme elevations come with a little pruritus, I think this is certainly the right time to specialized referral. And the other, if you're thinking about measuring serum bile acid levels and you find high serum bile acid levels, I think that's a very strong indicator of a significant liver disease, such as cholestatic disorders, PBC, PSC, or a hereditary condition, and this requires specialized care and management.
Completely agree.
Yeah, well, this was a very interesting discussion. Thank you so much, Verena. And I want to summarize, I think, the most important key takeaways. So I think we have learned that accumulation of bile acids lead to hepatocyte damage, but also to cholangiocyte injury, but could also have, and that's important, systemic effects on kidney, cardiovascular system, an issue in pregnancy-related liver disease, and vitamin deficiencies and fatigue. So measuring serum bile acids is indicated in these unexplained clinical settings. And the key scenarios is patients with pruritus and jaundice, unexplained persistent liver enzymes elevation, and suspected cholestatic disease, including intrahepatic cholestasis of pregnancy. But bile acids can also serve as a marker for estimating disease severity, and most importantly, also as an indicator for initiating bile acid lowering treatments. So to summarize, I think bile acids are central in diagnosing, monitoring, and managing cholestatic liver disease. So, Verena, I would like to thank you very much for your questions and responses.
It was always a pleasure.
So, thank you to the audience, and thank you for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation. Thank you very much.